respected seniors, dear friends and colleagues. Welcome to the API KOCHI meet for the month of August 2021. For this month's meet, we are indeed honored to have a renowned speaker and a world-renowned diabetologist, Dr. Jyothidev Kesavadev, for the first session. And this will soon be followed by a clinical case discussion of a post-COVID case that we presented from the government hospital, GH of Ernakulam. Now, for the first part of the academic session, may I invite Dr. Geetha Philip to chair the session, please. And Dr. Geetha Philip, MD, FRCP. She is, again, a very famous physician and a very good teacher. For excellence, she is the Director of Academic Affairs at Aster Medicity, Chairperson. She is also the lead consultant of internal medicine at Aster Medicity. May I now invite Dr. Geetha Philip to kindly come over and introduce the speaker for the next first session.
Thank you very much, Dr. Radhakrishnan and Sheetal, for giving me this opportunity. And I'm very happy for the good words you said about me. But I'm part and parcel of the API KOCHI, so you have to consider me as such. And first and foremost, before we go into today's topic, I would like to introduce Dr. Jyothidev Kesavadev. Dr. Jyothidev is well known to all of us. He has spoken on several forums. He's an alumnus of Trivandrum Medical College. He's got his MD from there. And he's got a FRCP from all the three colleges, Royal Colleges, London, Glasgow, and Edinburgh. And above all, he's got a fellowship in endocrinology from Mayo Institute. And what is very important is he has done several research papers and research work while he's based in Kerala. He's a very good speaker, a very good clinician, and I wish to welcome him to today's speech. And what exactly is going? He's going to take us through the new technologies available in the management of diabetes. So technologies have developed in the delivery system, in the monitoring system, and even in drugs. So I invite Dr. Jyothidev to speak to us on this without wasting time. Dr. Jyothidev.
Thank you. Thank you. Thank you very much, Geetha madam. And thank you very much, AP Radhakrishnan sir. And a special thanks to my friend, Dr. Prasanna Kumar, for this invitation and for this opportunity, and also to Dr. Sheetal for helping me out. So the topic which is given to me, of course, this is supported by Novo Nordisk. And so let me thank Novo Nordisk as well for supporting this program for API KOCHI. So in the next 25 to 30 minutes, I'll be discussing on the technologies and treatments in diabetes. And this will be definitely with a focus on the practical aspects of treating diabetes. And I won't be discussing in detail about the gliflozins or GLP-1 receptor agonist, which is already part of the treatment protocol. But I'll be focusing on that areas which will be very with profound help in bringing better outcomes, both in the short term and in the long term. So this is a recent statistics. So if you look at the burden of diabetes care in the country or globally, or with people with diabetes having a hemoglobin A1C of less than 7%. So, here you and this is IDCI, which stands for the India Diabetes Care Index. So remember, Novo Nordisk had a very prestigious project. So it has not had a prestigious project, it's still going on. And it was a 1,000-day attempt to bring down the hemoglobin A1C in our country by just to 1%, just 1%, because the average was very close to 9%. And they have selected even KOCHI among the cities to be considered. But so it was during that attempt, it was when this campaign was going on, suddenly there was an unprecedented increase in the number of cases. And then we had the COVID pandemic. Of course, that is a different story. But if you look at the overall picture, only hardly 20 or 22% of people with diabetes have a hemoglobin A1C goal. They are reaching a hemoglobin A1C goal of less than 7%. So why I am highlighting this is when we are tonight discussing on the emerging or the existing technologies and treatments for 2021 diabetes, there is a reason for that. The reason is, if you look at the different geographical locations in our country, 50 to 95%. So this is an alarming statistics. In some areas, even 95% of the patients are succumbing to the complications of the disease. And even doctors are not an exception, because every week we have 1 or 2 doctors as new patients in our hospitals. And even among the doctors, and that can be a physician or it can be a colleague from another specialty, but due to various reasons, even among our own colleagues, treatment of diabetes, as most of you will agree, is a disaster, is a disappointment, is a failure. There could be many reasons, and for the layman, for the common man in our state, when compared to many other states, unfortunately, there is a very high occurrence and there is a very high incidence of the use of complementary and alternative therapies. And I call it unproven therapies, many of them resulting in hepatic and renal damage. And they use it along with other medications, and sometimes they use it for a couple of years and then start treating with modern medicine. Another major reason. So even when we were having the lectures, so probably I could have lectured for APA and IMA more than 100 times in the last 1.5 years during this COVID-19 pandemic. And I found that most of us are still using the older human insulins. And many of us, our colleagues, are probably apprehensive of using the newer analog insulins and the newest analog insulins due to fear of hypo. Whereas in reality, the newer insulins are having a far lesser occurrence of hypoglycemia. The newer insulins have the same potency. The only difference is the convenience in the timing and less means significantly less occurrence of hypoglycemia. So if you compare degludec with glargine, U100 degludec with U100 glargine, there is more than 52% less occurrence of hypoglycemia during the nocturnal hours. And that has been well established in DEVOTE. So not adopting the newer technologies, not adopting the treatments that has been recommended in the clinical practice recommendations by the national and by the international scientific organizations. So that has been another major challenge. And probably some of us are still not having the diabetes educator, because the diabetes educators or the nurses or the dietitians need to spend more time educating, convincing the patients on the requirement of a glucose meter, the requirement of a structured SMPG, because many of our patients will be using a glucometer. But in the absence of structured self-monitoring of glucose, in the absence of generating a cloud data, connecting all those dots and downloading or either messaging to the doctor's office, the digital glucose diary, how can we transform the care for better outcomes? So all of us require the services of diabetes educators. And another large area, I witnessed a discussion during the COVID times and even yesterday in some of the doctors' forums. Should we be using statins or not? Even the doctors are discussing a time-tested therapy, and many patients will discontinue drugs, including statins, believing that it is unnecessary. It is unnecessarily being prescribed in diabetes. All the international scientific organizations, the American Diabetes Association, they are endorsing home blood glucose monitoring and home blood pressure monitoring. And we have also, in our own original research, we have proven and we have published that home blood pressure monitoring can retard or prevent the progression of diabetic kidney disease, along with structured SMPG and actionable information being translated to therapeutic and lifestyle changes. So things are changing. We are entering a completely new era. So for more than 50 years, for more than half a century, we have been testing glucose in urine with Benedict's reagent, then clinistics. Then we started using glucose meters, SMPG, then continuous glucose monitoring. Now we are transforming, and the international and the national diabetes organizations have endorsed time in range as the new prognostic factor, as the new glucose metric, which I believe all of us and all of you are completely aware. And this is the sample report which has appeared in the clinical practice guidelines from 2019 onwards. How you are expected to hand over a time in range report which is generated from the continuous glucose monitoring data. So as you are aware, you require at least 14 days of monitoring, of which at least 70% of the data is available, at least 10 days of data is available, so that you can have a meaningful information on not only the ambulatory glucose profile. So in the middle, you have the ambulatory glucose profile, which is a model graph representing all the 14 days. And you have the inter-day and the intra-day variability. But now we have started assessing and we have started measuring the glucose variability. And that is available here in the form of a bar. The green, the red, and the yellow, representing the time in range, the time below range, and time above range, respectively. It was at the ATTD consensus meeting. So we were all there. So I have been fortunately attending the ATTD for more than 14 years now. So that is the largest technology meeting for diabetes in the world. And the ATTD, along with ADA, EAST, and with many other organizations such as ISPAD, they have developed a TIR consensus. So why TIR? So whenever we discuss about time in range, this used to be a very common concern from the doctors. Do we have data? From A1C, we have data. With every 1% reduction in the hemoglobin A1C, there is 37% reduction in retinopathy, nephropathy, and neuropathy. With time in range, the data is more robust. The evidence is much more robust. With just 10% reduction in the TIR, when the TIR is reduced by 10%, retinopathy increases by 64%. So that is a number which is statistically and clinically alarming. And microalbuminuria increased by 40%. So if you can improve time in range. So time in range is defined as a glucose between 70 milligrams and 180 milligrams per deciliter. And with the aid of the newer continuous glucose monitoring devices, we can assess the duration spent in range, the duration spent in hyperglycemia, and the duration spent below range. And with minimal modifications in the therapy, all of us should be aiming for at least more than 70% time in range for all of our patients with type 1 and type 2 diabetes. And there are different targets for elderly with complications, with comorbidities, even for younger with other comorbidities and with a propensity for hypoglycemia. And for pregnancy, you have a completely different target. So I will briefly, I know that this is only a review for most of you since this has been discussed in all the forums, TIR for the last 3 years. So if I am to sum up TIR, between 70 and 180 milligrams per deciliter should be spent in general more than 70% of the time. And if you are aiming for 70 and if you can achieve better, every 10% increase will have phenomenal benefits, 0.5 to 0.8% improvements in the hemoglobin A1C and the phenomenal benefits in long-term outcomes in diabetes. And the time below range, there are 2 levels, level 1 hyperglycemia and level 2 hyperglycemia. Level 1 is below 70 and level 2 is below 54. And below 70 should be less than 4% of the time. And below 54, less than 1%, which corresponds to 15 minutes in 24 hours. And this is level 1 hyperglycemia above 180, and this is level 2 hyperglycemia above 250. And what about those with comorbidities and with a higher risk of developing a hyperglycemia? You have a relaxed target, similar to the 3 different targets in the elderly. For hemoglobin A1C, we have a different target, and this is more than 50%. So the more than 70% is replaced by more than 50%, but the range remains the same, 70 to 180. So there is a South Asia consensus coming up, where I am also a member, where we are having a different number for South Asia, since our population is different. Of course, in general, it remains the same, but in comorbidities, since the risk of hypo is more, to produce more of other consequences and complications, the level 1 hypoglycemia alone is being included, and that is below 70, less than 1% of the time. What about type 1 in pregnancy? Type 1 in pregnancy, the target is between 63 and 140. Remember, normal in physiology in pregnancy, the glucose value is very low. And even subtle changes in the glucose can be deleterious to the mother and to the baby. And hence, you have a tighter, stringent target for pregnancy and type 1 between 63 and 140, and the level 1 and level 2 hypo is below 63 and below 54, and less than 4% and less than 1% respectively. And we don't have sufficient clinical material and evidence to suggest a TAR for GDM and pregnancy and type 2 diabetes. For the time being, it is recommended more than 90% of the time between 63 and 140. But it is getting recommended, and it will be modified from time to time. So this is sharing a very glad news with you. This is the American Association of Clinical Endocrinology, ACE, a clinical practice guidelines for the use of advanced technology in diabetes, including CGM. And in the 2021 guidelines, maybe for the first time in the history of American Association of Clinical Endocrinology, a supreme authority, they have included and referred to an original research on CGM from India. And they have included the study in the creation of their guidelines for CGM. So time in range as a target. This is a recommendation from the Indian authors. And we have recommended, strongly we have recommended, that this is an urgent need for India, because we are failing in the treatment of diabetes due to many, many reasons. And glucose variability need to be one area which has to be addressed urgently. And time in range as a target in type 2 diabetes, and this can be used along with hemoglobin A1C, and the frequency of performing a test can be customized. So in persons whom you are having a better time in range and a minimal time below range, probably you need to have a TER assessment only once or twice a year, and more frequent whenever it is required. So available CGM devices in the country. Which are the popular and available CGM devices in our country? Of course, we have the Guardian Connect from Medtronic, and Medtronic has been the pioneers. And I still remember using the CGMS Gold, and it is still with me, and that was from 2005 onwards. And then you have the Libre Pro from Freestyle Abbott, and that is a provisional device which is black, which is white in color. The reader is white in color, and that is how you differentiate this from Freestyle Libre, which is the intermittently scanned device. So in the intermittently scanned device, over there you have a black reader over there. So this has been made available in India from 2020 November onwards. So this has been a real revolutionary phenomenon, a path-breaking device, since it has made possible for a intermittently scan, which is almost similar to a real time. And these two doesn't require calibration, whereas GC require calibration. So this is GC, and this is just a pictorial representation, symbolic representation of connected devices. So what are connected devices? So connected devices are Internet of Things in diabetes, is connecting the devices with the help of a Bluetooth or with the help of internet, so that wireless transmission of data is made possible. And also, you can remotely monitor your patients. So I will give you a few examples, and of course, some of these are available for a long time in our country. And this is currently not available, and this is an example of connected insulin pens. And InPen is one example. InPen is now acquired by Medtronic. So what do they do? The connected insulin pens are the same insulin pen. So in the picture at the top in red, it is the NovoPen Echo Plus. So you know, and you're familiar with the Echo, which is meant for children, where a half a unit of dosing is 0.5 unit dosing is possible with 800 injection dose memory. And it has a remarkable battery life of 5 years. Usually the pen lasts for 5 years. So the battery lasts for 5 years. And it is kid friendly. And the bottom one, you have the NovoPen 6. And this is an advanced gadget, which is NFC enabled. And hence the data, the memory can be transferred via Dyson, or it can be connected via Bluetooth to Libre sensor or a Medtronic Guardian Connect sensor. And then it can be again wirelessly connected to a dosing algorithm, which is there in your smartphone. And our patients can use the dosing algorithm in the smartphone along with a sensor, which is again wirelessly connected to the pen, and they can automate the delivery of injections. So ordinary multiple daily injections can be automated. So probably this is going to be a poor man's insulin pump in the future. So now the connected glucose meters. When I say connected glucometers, these are all having the price as same as an ordinary glucometer. There is no extra cost for the mobile app you're using. So this is an example of a one-touch video flex glucometer, and I can use a video, so I can show you the, so this is one-touch mobile app. So the mHealth applications, so they have a benefit of not only procuring or gathering or collecting the information from the glucose meters, but they can also create patterns. They can also create a digital glucose diary where the day and time stamp will be automatically collected from your smartphone. And this has also got functionality on having your diet, exercise, everything can be logged in. So another example. So here I have a voice along with this. So this is a short video just for a minute. So I am using my sugar. So just listen to this. This is my sugar, 126. So this tiny monster is, so if somebody is going to ask you, which is the most popular mHealth or a mobile app for diabetes, the answer is My Sugar mobile app. And this is used by more than 3 million subjects with diabetes, both type 1 and type 2 diabetes, available for a free download in more than 90 countries, including in India. And this monster, you have seen the monster over there, and this is going to be the diabetes companion with you. Highly motivating, and you can log in any information there. And it is partly automated. All the medications are listed there, all the insulins are listed. And remember, I repeat it again, this is available free of cost. And this is also an example of a connected glucose meter. And what about the upcoming newer insulin pumps? Because we have been using insulin pumps for more than 60 years now, and the insulin pumps are now getting automated. And we were waiting for a long time for an insulin pump without any strings attached. And of course, we will soon have the launch of Solo micro pump. And this is again from the same My Sugar, and that is AccuCheck. So AccuCheck has got the AccuCheck Instant, which connects with My Sugar app. And this is AccuCheck Solo micro pump with AccuCheck Aveva Solo as the handheld remote for the pump. So this is an example of a pump which doesn't have any tubes attached. But again, another path-breaking technology getting launched in the month of September next year. And this is from Medtronic, the 780G. So there are thousands of patients in our country using 640G, which prevents insulin from getting delivered at least half an hour before the onset of hypoglycemia. But in contrast to that, this comes under the description of an automated insulin delivery device, AID. So in an automated insulin delivery device, in addition to the pump, so I would say that there are not much differences in insulin pump. Insulin pumps are remaining almost the same. They're all the smart insulin pumps. But the difference is with the glucose sensor. So I have shown you many sensors and they're advancing a lot. The generation, with every generation, with each generation of the sensor, the accuracy is improving, and with the help of newer algorithms, we have been capable of overcoming the lag time. So this is sensor with a pump and with the algorithm. So it is automatically adjusting insulin delivery every 5 minutes, And it is correcting not only hypoglycemia, it is also correcting hyperglycemia. So in response to hypoglycemia, the insulin dose is coming down, and with response to hyperglycemia, there is enhancement in the dose of insulin delivery. So this could, I don't say this is 100% foolproof, but almost 70 to 75% time in range, and up to 80% time in range is possible with Medtronic 780G during the nocturnal hours. And this is again a representation of AID, and earlier we used to call it artificial pancreas, and that was a misnomer. So we have an insulin pump, and this is delivering insulin subcutaneously, continuously. And then you have an advanced insulin, advanced sensor, and this pump can function only with a sensor from Medtronic, and that is also the new gen sensors. And then you have an advanced control algorithm. And this control algorithm could be model predictive control or a fuzzy logic. And the newest 780G, even if the bolus dosages are less, it will not only change the basal, it will also provide the bolus automatically, partly automatically. So this is for the first time we are going to witness the launch of a self-adjusting insulin pump, self-adjusting both basal and for new auto-correction bolus dosing. So the do it yourself, and this is DIY artificial pancreas. So some of you probably will be familiar with this. And today I saw an article in the week written by Dr. Mohan, and along with the first user of DIY artificial pancreas in our country. So DIY artificial pancreas stands for AP devices or automated insulin delivery devices, which are created by patients themselves, because some of these algorithms are available online, and you can procure some earlier insulin pumps or some of the newer insulin pumps from Omnipod, and then you can create your own device with the help of a third party, and that again can be purchased online. And one example is a Riley link. And why this has happened? Because I told you that with the available devices, most of them will provide you with 60% time in range, or a 70% time in range, or an 80% time in range. But the first user of artificial pancreas in India, DIY from India, and that is none other than Jyothidev, the celebrity dancer and founder of Diabetic. According to her, and what we have seen, because we have been involved in creating DIY for her, and from her narrative, we have seen, some of you could have already read this article. It is more than an incredible 95% time between 70 and 180. And according to her own personal experience, what she's telling is, for the first time in her life, after the diagnosis of type 1 diabetes, she is now living without the mood swings of hypoglycemia, where she gets several episodes of hypoglycemia, including when she was traveling. But for the last 3 years, she had never experienced a hypoglycemia in her life. And for those colleagues and friends who would like to have more information on do-it-yourself artificial pancreas, this is a review that we published last week, which is classifying all the available devices and technologies. And this is a story, and this is a timeline of evolution of insulin delivery devices. Insulin delivery devices starting from the discovery of insulin. And from Novo, we have one of the most advanced delivery system, and this is FlexTouch. FlexTouch is that disposable device which is available along with the co-formulation, that is Risoduct, along with the Degludec, and there is an end of dose confirmation, and it enhances patient confidence. And this is the only pen, only pre-filled pen, which doesn't have a push button extension. And there is an easy touch button. And for elderly with Parkinsonism, with tremors, it has the lowest injection force. And look at the letters over there. Very big, large, easy to read scale. So these are unique features of this delivery system. And for the insulin, and for this co-formulation, which is the next gen for the premix insulins, even though you have two insulins within the same cartridge, with advanced technologies, it looks clear. There is no requirement for the stipping or resuspension. So there is no reason for any resuspension in this. And the PK/PD properties are distinctly separate, and it is still maintained within the same solution, even though both are mixed in the same cartridge. So it is so unique, and it is so specific to Risoduct as a co-formulation. But let me spend another 1 minute with an upcoming technology. And this is again a dream come true when we are all commemorating 100 years of discovery of insulin. We have for the first time a peptide in a pill, a protein in the form of an oral medication. And if you look at the challenges over the last 100 years, because we have never been successful in diabetes in creating or in developing a protein which can be provided in the form of a pill. Because if you ingest a protein in the acidic pH, there will be proteolytic enzymes and it will be digested, and there is limited permeability. But how has this been overcome? With oral semaglutide or Rybelsus, which is currently approved by Indian DCGI, and we are all waiting for its arrival in India. And with this new Rybelsus, 3 strengths are available: 3 milligrams, 7 milligram, and 40 milligram, to be ingested on an empty stomach with 120 ml of water. So when you are ingesting, so this is going to be an animated slide. So it comes into close proximity with the gastric mucosa, and now it is going to burst there. So it is going to be permeable. So it increases the local pH. So when it increases the local pH, it can overcome the proteolytic digestion. So it is co-formulated with SNAC. So everything has been made possible by co-formulating this with SNAC. It increases the local mucosal permeability so that semaglutide is absorbed across the gastric epithelium into the systemic circulation. And this has become a real path breaker. And the molecule has been extensively studied in clinical trials against placebo, against the contemporary popular therapies such as empagliflozin, sitagliptin, against insulin, against GLP-1 receptor. And if you look at the clinical trials over there, there were a substantial number of patients from India being recruited in most of these clinical trials. And now there is an ongoing sole clinical trial, which is exclusively for the superiority to be defined for oral semaglutide with respect to cardiovascular outcomes. And this is with placebo and active control trials, the efficacy of semaglutide based on duration of diabetes. This used to be a very common question. In which phase or stage of diabetes I should be using this new GLP-1? Whether the duration of diabetes is going to be less than 5 years or between 5 and 10 or more than 10 years. If I am eliminating the comparators, the efficacy remains the same. So this is towards the fag end of my presentation. Glucose is now a vital sign. The 5th vital sign, the international consensus from the IDF upcoming president, RSSDA president, from Padma Shri Anu Mishra, the Diabetes India president, Dr. S.R. Arvind. So the consensus is to adopt blood glucose as the 5th vital sign, along with the other existing vital signs. And this has to be implemented even in the absence of diabetes. Even in the complete absence of diabetes, in all our hospitalized patients or getting treated at home, we should be measuring glucose. So this is a bird's eye view of our virtual COVID IP care. So we have been treating patients via telemedicine, and this includes interventions as well. And we have shared the success story in an international journal on the new interventional home care model for COVID management. And for those doctors not aware of our monthly diabetes journal, we have been publishing this for more than 14 years. And this is an upcoming journal, the International Journal of Diabetes and Technology, with an international editorial board published by Walters Clover. And I request all of you to participate and to submit. And this is only to promote and encourage original research in diabetology from our country. So once again, I thank you, all of you. And this is my take-home message. Best treatment need to be given to, provided to our patients, and that too at the right time, without any delay. And for this, we request sound knowledge and common sense in science. So thank you very much, APA KOCHI, for this opportunity and for the patient listening.
Thank you very much, Dr. Jyothidev. It was a very elegant, very simple, very informative talk. You have taken us through newer technologies. You spoke to us about the newer analogs and the reluctance of many of us to use that. You told us about time in range. That is very important. Many people are still to catch up on that concept, though many of them know it. We are still using fasting, postprandial blood glucose and HbA1cs. And not many of us, I think, are using the continuous glucose monitoring system. You have taken us through the path-breaking devices, the automated insulin pens, the connected glucometers, and very, very interesting is do-it-yourself pancreas and the oral semaglutide. These are very interesting topics. So I think it will take a bit of a time for us to catch up. And I'm sure in the audience, there are many people who would like to ask you questions. So I think they're open for discussion.
Hello, madam. Am I audible, madam?
Yeah, we can hear you. We can hear you.
Madam, I have got certain doubt. The sir has told that there will be the degludac hypoglycemia less with degludac compared to glargine. But the recent trial, that control trial, has shown that overall hypoglycemia with glargine 300 and degludac is more or less equal. So, which we have to believe?
Okay. I will clarify. What I said is to use the newer analogs. There, as you said, what I mentioned was about devout clinical trial, not about the newer trials. The devout clinical trial, which was a cardiovascular outcome trial between U100 glargine and U100 degludac. So when you compare with U100 glargine, there is a 53% reduced hypoglycemia with degludac. But when you compare U100 degludac with U300 Tresiba or glargine, there are a couple of studies which I am well aware because I am a speaker for both of them. So I am also confused. But if you look at the data from many other European countries, maybe these two insulins are interchangeable. So both of them have a far less occurrence of hypoglycemia, maybe 15 to 20% less hypoglycemia when compared to glargine. So U100 glargine is Lantus and U300 glargine is Toujeo. So Toujeo, when compared to the conventional glargine, is having a far less occurrence of hypoglycemia. But with the Ryzodac, you have degludac, because degludac is an insulin with a efficacy which is superior and with a hypoglycemia which is proven to be lower for overall as well as nocturnal events. So they have separate studies for overall hypoglycemia and nocturnal hypoglycemia. And when in the Indian scenario, many of us are tempted or forced to use a premix because of the high carbohydrate, because of the late insulin initiation. And in such cases, if you are using degludac along with aspart, that becomes the best insulin. For the precisely for answering for your question, U300 degludac, U100 degludac, and U300 glargine probably is similar. But when you compare U300 glargine with U100 glargine, hypoglycemia is less. It is significantly less with U300 glargine. I believe
Sir,
I have answered.
Sir, yes, sir. I had another doubt is here that the semaglutide, when there is a report of more incidence of retinopathy when semaglutide is used. And another doubt is that when we suppose a patient is taking this proton pump inhibitor, will that snack changes the pH? Suppose the patient is already on proton pump inhibitor, will that interfere with absorption of semaglutide?
Excellent question, sir. Excellent question. Both of these are studied in the clinical trials for the regulatory approval by the FDA for semaglutide in the US, because Ribelsis oral is already available in the US. They have done clinical trials for omeprazole with omeprazole. So they have found that there is absolutely no reason why omeprazole is changing the pH. The only requirement is they have to be ingesting this fasting along with 120 ml of water, and the snack will take care of the pH. Snack will take care of the local pH. And that is only transient increase in the pH to overcome the proteolytic digestion and to increase the local mucosal permeability, which is also transient. And for your other question on retinopathy, remember when the GLP-1 clinical trials were ongoing, maybe 8 years, 9 years ago, we were also part of LEADER. And when exenatide or liraglutide, all of those were introduced, there were a lot of concerns on increase in amylase and lipase in the clinical trials, which later on in the real world, we found that it is of no concern at all. It's of no clinical significance at all. So similarly, the minimal occurrence of retinopathy, which was seen in the earlier trials, it has been said to be because of the sudden, rapid change in the glucose, rapid correction in the glucose. And in the DCCT, which is the trial in type 1 diabetes, diabetes control and complications trial also, there was a sudden worsening of retinopathy. And this was long ago. And this happened because of sudden reduction in the glucose in the children with type 1 diabetes. So when we are using semaglutide, because semaglutide, when compared to many other GLP-1, the efficacy is far better. The hemoglobin A1C lowering is not just 1 or 2%. It can be even up to 2 to 2.6% against placebo. And the weight reducing capability is also more than 5, because it can reduce the body weight up to 8 kilograms. So you should be gradually titrating the dose of drug along with the other medications, because we are also part of clinical trials with oral semaglutide, but we have never seen any worsening of retinopathy. Any reason, because this is not going to be a clinical challenge, and there is a real world experience as well, since semaglutide, both once weekly injectable, that is Ozempic, and once daily oral, that is Ribelsis, is available in many other parts of the world. So it is a blockbuster. So there are no clinical concerns.
Dr. Jyothidev, Dr. Radhakrishnan, I think we are running short of time,
Yes.
and we have a very interesting case coming up, and it would not be fair to them if we take all the time. So Dr. Jyothidev could speak to us on another occasion and clear doubts. Dr. Radhakrishnan, what do you say?
Thank you, sir. Thank you, madam.
Certainly, ma'am. We will have another occasion for clearing the doubts. Thank you.
Dr. Jyothidev, I am sure there are a lot of questions. I'm sorry to be in a hurry, but that's not the reason. The people behind us also should get a chance.
More important is COVID. More important is COVID discussion. So I will also listen to this. Thank you so much.
Thank you very much.
Thank you, madam.
Thank you so much. Thank you so much, ma'am, for chairing this session. It was so wonderful. You did it very well, ma'am. Thank you.